I welcome Dr. Anitha Balachandran Madam. She is a professor in RIO Trivandrum, a great teacher and with a great expertise in the area of refraction. So, welcoming ma'am.
Thank you, Grishma, for that kind words. I thank you and the KSOS for giving me or including me in your IC. In spite of all the ongoing advances in ophthalmology, we will definitely have a significant people or patients who need glasses. So dealing with them, we should see what are their causes of dissatisfaction and how to deal with that. This was a lady who is a teacher by profession who had come and told that he was having the same power made in the different frame, but she can't drive with that. What do we usually do when a patient comes with complaints of glasses? We check the vision many times monocularly with the present glass, check the power of the present glass. We'll see whether it's corresponding to the prescription. Maybe we will repeat the refraction and tell them everything is okay. You're having good vision with each eye with the glasses. This must be some problem. You go back to your optician. So what are we supposed to do? Like Grishma said, we should be calm. Spectacles are not so simple things. It's many a time it's expensive, or they want their vision to be okay. So we have to be calm, relaxed, and have, like she said, we should listen to them with empathy and without knowledge as to how to proceed. No composer or empathy is going to work. So what will be the complaints of the patient? Most of the patient will say blurred vision, can't see. But we have to go into details at what exactly is the vision. At times, it will be systemic sort of symptoms like headache, dizziness, vertigo, or maybe even vague. We can't decipher what exactly they're saying. At times, they will say blurred vision. But they say blurred vision, it might be, we should go into it detail. It might not be the proper decrease in vision. It might be distortion. It might be tilt. It might be size disparity or judgment error. So go into the details of what exactly is the visual complaint is. Sometimes it will be mechanical problem like frame fitting or bifocal segments not able to read like in the old glasses, etc. So where is the mistake? It can be prescription errors. It can be dispensing errors, or sometimes optical effects inherent in the lens, possibly caused by the dispensing or prescription errors. Prescription errors, as we know, it might be due to some incorrect refraction. When you copy it into your prescription chart, you might sometimes change the notations or make some, you write it in a way it is not decipherable, like that. At times, it will be failure to include the vertex distance in the prescription, which many a time is not done. Especially in higher powers, where it is mandatory that we should include the vertex distance we had been checking the patient with. And many times we give glasses for near vision for the reading, and the patient might also will be checking reading. He might even forget that he is using it for his occupation as well. He might be a person who is looking down at things or in the mid height. So the occupational requirements do have an important role in. At times we will have to give a different set of glasses for his occupation as well. And checking if his diabetes or if it is a diabetic status is controlled is another importance. And in pre-presbyopes and presbyopes even, sometimes there will be hypermetrope and they'll be using all her accommodation or the reserve to get his vision control, and manifest hypermetropia becomes manifest only when they're using it for longer time in practical use. So these are the things which are often overtaken. The dispensing errors is when you the dispensing place, when they copy the prescription, it might be incorrectly filled, the plus and minus might be changed, the ad might not be appropriate, or when they send for making it, it might be transcribed in a wrong way, and the optical center positioning wrongly is one of the commonest errors. And like I said, the vertex distance conversion, especially in higher powers, when it gets converted, it might not be having the adequate power or more power. The bifocal placement and unnecessarily changing the bifocals which the patient has been comfortable with earlier into another stylish, or the patient also might ask for it. It might not suit for his use. And the changes in the thickness and the base curve of lenses are made many a time without he or the doctor knowing about it. And the frame is selected as per the patient's choice, which might not choose or suit his facial structure. And the optical defects are mostly due to change in the base curve, thickness, the change of the type of the bifocals. Even the progressive addition lenses might be changed into another type. He might be having a PAL with a good reading area, and the frame size will be suddenly changed and the reading area becomes small, causing a peripheral distortion. And to make the glasses light, we go in for high index lens, but it can have peripheral chromatic aberrations causing this rainbow effect. Some lights coming in the multiple chromatic lights coming in the edge of the lens, especially while you're passing along the way where you have lights on the either side. Sometimes the environment will be curving towards you like in a bowl. That's called fish bowl effect. At times you'll have wavy or swirling movement of the floor or the objects you are looking at, which is the swim effect, all caused by the lens, the optical effects of the lens, which they might adjust within 1 or 2 weeks. If not, it might not be an optical problem of the lens, it might be the other causes, which is they are not going to get adjusted. We all say that, yeah, everything will be okay. You come after 2-3 weeks, you have to get adjusted to the glass. This adjustment is mostly possible only because of this optical effects. Even that, if it is not contained within a few weeks, we have to go into find what is exactly the reason. And especially when you have significant anisometropia or high emmetropia, there will be fusion problems. So the correct refraction, like you have to fog and you have to identify you have to relax your accommodation, you have to balance binocularly. Binocular balancing is something which you are not using, you're doing it regularly. We do monocular subjective refraction, we never balance both the eyes. All this may cause fusional problem and sensory problem when you use it in long term. So when you change something, the patient has to be warned and aware, the patient has to be made aware that some changes will be there. If you're not getting adjusted, let us see what exactly can be done, especially when it's the patient's choice. These are when you go into evaluation tools as to what is the problem, there are certain instruments which we are not using regularly. We should have that for a better evaluation. You have a pointer? This is a lens caliper. This is a lens caliper by which you can measure the lens thickness. This is a lens clock which measures the base curve of the lens. And this is a distometer which measures the back vertex distance, the distance from the closed eyelid to the back of the spectacle lens, which can even be done by a simple millimeter ruler. And all this distometer do have this conversion guide. For example, something we have given as 15 at 12 millimeter. We have forgotten to include the vertex distance, and the optician make it at 6 millimeter because of the frame he has chosen, and the power will be different and will cause the patient blurry vision. And this can be made into a very simple way, even by your millimeter ruler, and write it, especially in higher powers more than 6. And when you work up, you get a proper history of what is the nature of the difficulty, go in deep into it. And examination, we have to examine the vision of each eye and with both eyes, both for near and distance. And what exactly what is the optimal reading position of that patient, and what is the smallest print he can read, whether his vertex distance given in the glass is more than what is required. And what is the optical centers, IPD, facial asymmetry, what is the type of bifocal segments he had been using and what he is using now, whether the height, the type, the position related to each eye is different from his old glasses and the new one, and what is the size, have you gone in for a frame of different size, vertical and horizontal. And not to forget about the base curve and the center thickness. And never forget to perform a repeat refraction if all the above are found to be satisfactory. And at times, in young patients and pre-presbyopes, cycloplegic refraction may be needed at times. And when you have an older glass, better if you have the older prescription, always compare the prescription and the glasses, both old and new. And what are the prescription errors? For the refraction error, many a time, like we said, it might be the lack of fogging or the action of the non-relaxing of the accommodation causing under plus of hyperopic or over minus, both of which are known to cause headache and asthenopic symptoms in people with active accommodation. And sometimes the astigmatic axis, he has been using it, he will be very much used to it. When you refine it and when you do it, it might be a little different, and that might be the right one also. And you have prescribed his right axis, maybe 90, but he might have been used to his 80 or 110, and this sudden change will cause his problem. So it's better you can cheat the axis and go back to his original axis, especially in a person who had been wearing it for quite long time. That is cutting the cylinder and cheating the axis. We also know for the patient comfort, not in a person who is getting it for the first time. There you can have your right thing. And suppose you see a patient pulling his frame or pushing the frame front and back, it might be due to his power getting different when you put it at various distances, like convex, how it varies when you pull it front and pull it back. Or it might be the vertex distance problem if it is a higher power. So that movement itself shows that his power given is not what he needs. And choice of bifocals. Many a time we give what is a bit too strong. Suppose the patient is reading adequately with +2 and +2.25 or 5, it is better that give the lowest correction. We should have a range of near vision, some 6 centimeter ahead and towards from his working distance. Only then he'll have a comfortable working distance, working ability with his near ad. And a second thing is the loss of focal range. The patient has to be made aware of that, especially when the power has changed into a more plus. You have given the right power. You have done a good refraction. You have given the right power. But with his old glasses, which is of less power, he is used to work in his mid distance more comfortably. Or the counters of the kitchen and the cupboards especially will be in the mid-range, and he might be seeing that with, okay, we check the long distance and make it 6.6. Suddenly when she gets the new glasses, she won't be able to do the work which she has been comfortable with his old glass. So this focal range problem is a problem when you add plus or add minus. Such a situation, if it's a bifocal glasses, it is better we explain to them and change into a progressive addition lenses. And dispensing problems, the frames might be, that frame problem is easier. It might be a small frame which he had been used to a larger frame with a larger reading area. When you reduce this frame, you will reduce the peripheral distortion, but the reading area will be less. If you do it reverse, the peripheral distortion will be more and the reading area will be less. So in the loose frames, which will slide down, and the bifocal segment also slides down, making it difficult for reading. I had a patient who told that everything is right, power is right, near ad is right, but she was saying, "Kannongi kedakana," because it has been slide down and she's reading well with lying down position. And again, regarding the frame fitting, one important thing is the pantoscopic tilt. When we take the glass, the tilt is the tilt from the upper edge of the lens, the frame, to the lower edge. It should be less than or not more than 7 degrees. So these are usually the frame problems. This is a very flimsy plastic frame which can bend and break, and this frame is sitting so much high up on her nose. So again, the vertex distance will be varying, and this frame, the bifocals mostly is at her cheek, and this is quite large frame. And this was our patient. See, this is a almost good frame with the nose pad. See, it is sitting in the right position here. The frame has been made larger, and not only you can see a tilt, and the nose pads are quite tilted, which will induce unnecessary astigmatism and tilt of this environment. So when you give these frames, there is something of the height of the frame, the width of the frame, and the distance between the lenses, which is all written in the leg of this frame. So I'll have a look at the old frame and the new frame. And the simple trick as to what is the size of the frame each person needs is by your credit card. If you put your credit card edging at the nose and see at the distance of the canthus, if the credit card is inside the canthus, he needs only a small frame. If the canthus and the credit card distance correspond, it's a medium size frame. If the canthus is the card edge is inside the canthus, such persons need a large frame. The patient might be looking for a larger frame for the trendy ones, but we have to check if it suits him as well. This is the pantoscopic tilt. We have to see through this side, see how the tilt is from the upper to the lower, and this angle ruler is the instrument by which you can assess. This angle ruler is made to correspond onto your glasses, and then you adjust your face such that here you can see there's a gap. So you adjust your face such that the upper edge touches the angle ruler, and then the angle ruler is tilted to see where it touches the lower edge. See, this is adjusted to make it 0, and here you can see when it is corresponding to the lower edge, you have got something about 4 or 5. That's a good pantoscopic tilt. So many a time the pantoscopic tilt is the one causing a patient reading problem. So optical problems mark the one common thing is the optical center, which we should know that the optical center should correspond to the IPD of the patient. Even if you don't have a lensometer, you can check the optical center of the lens. All you have to do is shine a torch onto the backside of these spectacles. You will get 2 reflexes. Make it to correspond into a single reflex, and that's the point of center of that lens. The same is done to the opposite lens of the frame, and you measure it and see if it corresponds to the IPD. So the marking or writing the IPD in the prescription is very important. And changing the base curves and thickness, we should have a high level of suspicion once everything else is okay. And this is the IPD. You have to measure with this IPD ruler, and you can see that the IPD being 60, you have to check the individual monocular one also from the nose bits to this. This corresponds to about 30, and the other side also is 30. But you have also, the importance of checking this in each eye is that if you check it 60 and give it 60, it might not be so. This patient is also having 60, but here it is 28 and the remaining, though the total is about 60. So at times you will have to check it if there is a facial asymmetry. There will be difference in this IPD when you check it in each eye. So that also adds to the prism effect induced if the optical center doesn't correspond to the IPD. This is the problem when you suddenly change from one PAL to another. See the difference in the reading area and the peripheral area causing decreased area of reading and peripheral distortions. And nowadays many shops do have such instruments where everything is measured in one go, like all, including the pantoscopic tilt, height, what exactly each person needs. Everything is measured and given in a chart, and if that is followed, you can have a good satisfied patient. And this is a patient whom I have to see every day in my life. He is a doctor by profession, and he is high myope. He's even glasses, near glasses. So this is his refraction, the reading. He is wearing a multifocal, progressive addition lens also. But his requirement is that he's happy while reading and happy while looking at the distance and driving. But he needs multi-distance working. He'll have to write, he'll have to see at his patient, he'll have to look at the waiting area. And so what I did was, I made one clip-ons like this, with I add of again a 0.75 and had it clipped onto his lens. We can't even identify it. At times when he wants to look at different distance, he can raise it, he can do the reading, he can do whatever he wants and making it. So satisfying the patient is more important. So if you know the knowledge and the skill to deal with the knowledge and the expectation of the patient, that's the solution. Thank you.
Beautiful correlation of theory with clinical scenarios. Thank you, Dr. Anitha Balachandran, madam, for such a wonderful presentation.